So, Dr. Kanatha Rasalingam, he is a senior consultant neurosurgeon in General Hospital, Kuala Lumpur. He is also the Vice President of Neurological Association of Malaysia with a special interest in spine surgery, and he will be giving us our next talk, which is on MIS in lumbar canal stenosis. Dr. Rasalingam, you can do your share screen, please.
Yes. Okay. Can you all see? Yeah.
Yes.
Good evening, everybody. Welcome. Thanks for giving me the chance to present. I'm from Kuala Lumpur, Malaysia, and my topic today is on MIS for lumbar canal stenosis. So, goal of minimally invasive spinal surgery is to achieve outcomes equivalent to those of open surgery while minimizing muscle dissection, disruption of ligaments, attachment sites, and collateral damage of soft tissues. So the reduction in trauma has been shown to reduce immediate negative effects, such as pain and disability. However, from what our esteemed speakers previously have said, the long-term outcome has not been clearly demonstrated. So minimally invasive spine surgery offers several advantages over open surgery, which typically requires large incisions, muscle stripping, more anesthesia, a long hospital stay, and a long recuperation period. So in short, these are the benefits. A few tiny scars instead of one large scars. However, if you look at it, sometimes, when you are doing MIS, that you have got multiple scars. But if you actually add them together, they might be actually longer than the one scar in the conventional surgery. With the shorter hospital stay, a few days instead of a few weeks, or maybe about a week, reduced post-operative pain, shorter recovery time, less blood loss during surgery, and reduced risk of infection. So I will be talking about the overview of lumbar canal stenosis, the incidence, pathophysiology, and the types. And then I will go into the management of lumbar canal stenosis and the MISS techniques for lumbar canal stenosis, which will include microscopic and endoscopic. So lumbar canal spinal canal stenosis is a degenerative lumbar spinal stenosis. Describes a condition in which there is diminished space available for the neural vascular elements in the lumbar canal, secondary to degenerative changes in the spinal canal. So, as we all know, the pathogenesis, it's a disease involving the disc, the superior inferior vertebral body, and the facet joint. So any of this pathology, when they have got, when they have degeneration, they could cause a decrease in the space, which would cause stenosis. The facet begin to degenerate by developing synovitis, and this is the facet capsule, which causes greater spinal motion, which in turn will cause degeneration of the disc with osteophyte formation. So osteophytes can stabilize the motion segment, but can also narrow the spinal canal. So osteophytes on the superior articulating facet narrow the lateral recess, and osteophytes on the inferior articular facet narrow the central canal. So as you can see here, so this is the cross section over the L4 vertebral body, and as you can see, these are the main structures. Okay, vertebral body, this is the pedicle, this is the superior articular process of L4, inferior articular process of L3, and the transverse processes. So as you can see, any structure around here will, if there is some amount of degenerative changes, can cause lumbar canal stenosis. So how do we classify lumbar canal stenosis? You have got central, it could be central, it could be lateral. Lateral would involve the lateral recess, or it could be foraminal or extraforaminal. So as you can see here, okay, this is the central herniation. This is the paracentral or paramedian herniation. This is the foraminal, and extremely lateral will be the extraforaminal. So what do the patients normally present with, or what are the clinical symptoms? Typically, patients present with back pain. They can have, but of course, the most common presenting complaint would be intermittent neurologic claudication. Sometimes they can have buttock pain, posterior thigh pain, dermatomal radiculopathy, myelopathy, or they could even have neurogenic bowel or bladder involvement. So, of course, once we have the symptoms, we go to we do the MRI, and so of course, by diagnosis, if the mid sagittal diameter is less than 10 millimeter, it constitutes lumbar canal stenosis. In the MRI, we can also look. There could be a loss of this height. We could also see osteophytes. There might be. We have to look for facet joint arthropathy and effusion as well, and see whether there's any spondylolisthesis. And if there is a translation of more than 5 millimeters or rotation more than 10 to 15 degree on dynamic dynamic studies, that will show or point to instability. Another sign that we can look for is redundant nerve root sign. So as you can see here, the pointing to the redundant nerve root, and around it you can see a lot of tortuous vessels. So this is the redundant nerve root sign. So what do we do? How do we treat it? So I think even the speakers before me had mentioned, we only offer treatment for symptomatic lumbar canal stenosis. We start with the basics, which is physiotherapy, painkillers, and if that doesn't work, then we give patients epidural steroid injections. And finally, if there's even all this fails, then we work with the patient. We counsel them for surgery, and then we either we normally choose between an open or a MISS surgery. So the surgical choices we have: open or MISS surgery, or fusion or non-fusion. So these are the few of of what literature has quoted. Minimally invasive surgery for lumbar spinal stenosis, taken from the European Journal of Orthopedics in 2016, published by Walter A. Mogen and Niels van der Gaard. They conclude that surgery for lumbar spinal stenosis can be performed in a micro decompression fashion without standard instrumented fusion or an interspinous process device for equal or better clinical outcomes against lower cost. So I'll just go through a few more. Most of these are quite new studies. And also this study in Neurosurgery Volume 80, 2017, lumbar spinal stenosis associated with degenerative lumbar spondylolisthesis. It says in patients with LSS and DS, minimally invasive decompression is associated with lower reoperation and fusion rate, less slip progression, and greater patient satisfaction than open surgery. Decompression for patients with predominant radical pain has been shown to offer the most beneficial long-term outcome. Additional instrumentation could be added in patients with history of back pain and those with disc and facet joint degeneration with associated spondylolisthesis at the index level. More long-term studies are needed to assess the benefit of MIS techniques. Publication in the Asian Spine Journal by Seong Yup Lee and Tae Hwan. Update by review of literature. Patients with symptomatic stenosis may present with one or more of a combination of axial pain, radiculopathy, and neurogenic claudication. The long-term outcome of patients with lumbar canal stenosis treated conservatively was equivalent to the patient treated surgically. Decompressive surgery is the gold standard for treatment of central or lateral recessed lumbar stenosis. Additional fusion is required if there is associated instability. resection of more than 50% of the facet joint, degenerative spondylolisthesis, scoliosis, kyphosis, and previous decompression at the same level. So this is another interesting presentation on unilateral, unilateral laminectomy for bilateral decompression, ULBD. So this was presented in the efficiency of unilateral laminectomy for bilateral decompression in elderly lumbar spinal stenosis. And for this, they came up and they said that the indication for this would be mainly lumbar canal stenosis when central or lateral, or it can also be done as a part of decompression for fusion surgery. And the advantage of this unilateral laminectomy would be minimally invasive. It preserves the facet joint, inter and supraspinous ligaments and muscles, lower reoperation rate for instability, comparable or better outcome than open decompression. So as you can see here now, we can do bilateral decompression by using MIS technique. So this is a conventional. We go straight in. We add for the site of where we open, but we can also access the contralateral site using the same opening by a slightly, by undercutting our normal laminectomy site slightly. We can actually access the contralateral site as well. So as you can see, this is the conventional bilateral, laminectomy, and this is the unilateral. So unilateral laminectomy for bilateral decompression. So we only open this part, just the bit of the lamina, and we undercut the lamina on the other side as well. So as this is how it used to be before, but now with this, just this opening and sparing the spinous process, we can actually access the other side as well. So the surgical technique, I'll just go very, very quickly through it. The same position, prone position. We identify the level of interest using fluoroscopy. Normally, we go about 1.5 to 2 centimeter from the midline for a unilateral, and we can go up to 3 centimeter for bilateral decompression. We insert a 22 gauge spinal needle and identify this level. Once identified, the skin incision is made, and then we pass it. So this I'm talking about, we are using a tubular system. So we put in a guide wire, and care must be given that it lies on the lamina of the internal level. So I think our speakers before also have mentioned, it has to be docked very, very nicely on the lamina of the vertebra above. So it should be on the, if we are going on, say, L4, we are going for L4, L5, we want the L4 lamina, it has to be docked on the L4 lamina. And we have to make sure that we are sitting nicely on it and not too medial, because we don't want to plunge into the spinal canal. Of course, we introduce serial dilators, and we introduce it one by one. Of course, we confirm the position using the II. Area is clean, and all the soft tissue is removed, and lamina is identified. Then we take off the inferior part of the lamina until we can see the attachment of the ligamentum flavum. So we take off as much as we need to, and then we start taking off the ligamentum flavum using Carrison of different sizes, Carrison 1 and 2. And the extent of laminectomy is determined by whether we want to do a unilateral or bilateral. So if we want to do a unilateral, we just stick to that side. If we want to do bilateral, we finish the side that we are working on first. And then once we're done that, we can actually tilt the bed. Sometimes we tilt the bed a little bit and adjust our microscope so that we're able to see the other side. So these are the surgical incision that we make. Normally it's 2.5 centimeters. And then as we can see, all the nerve root is the cranial part and the caudal part. And this is the tubular retraction system that we use. So as you can see, A is the conventional if you're going to do a unilateral. But if you want to go into the contralateral, we probably need to tilt it a little bit. So we might have to, as you can see, the incision could be at least about maybe 2.53 centimeter away from the midline. Sometimes we also use endoscopic assisted decompression. We put in an endoscope to help us for better visualization. But most often, a simple microscope is enough. As you can see very well, we have taken off all the ligamentum flavum, very nice decompression. And this is the view when we are using endoscope. It gives us sometimes a better view, especially in areas which we are not able to see quite clearly with the microscope. So in conclusion, lumbar canal stenosis is a common cause of back pain in elderly. As survival age increases, more and more of this disease will be apparent in clinical practice. Surgery is offered in those with persistent and worsening clinical symptoms and failed medical management. Instability is the major concern in lumbar spine decompression surgery. Hence, MIS techniques in lumbar spine decompression offers a good alternative to open decompression with preservation of stability, motion, and good clinical outcomes. Various MIS techniques are available. It all depends on the surgeon's preference. MIS technique provides a steep learning curve, as mentioned before as well. And these techniques provide safe and good outcome in trained hands. Thank you very much. I would like to thank Divya and the team for inviting me. That's the end of my presentation. Thank you.
We need some questions here, some discussion.
Sure.
Yeah, this is my basic question that does the tubular retractors preserve the multifidus muscles?
Sorry?
Does the tubular retractors preserve the multifidus muscles?
From my experience, because we are not really cutting the muscle, so I feel that it preserves the muscles.
Yeah, this is an amazing thing which I've been thinking for a long time. I've seen the surgeons who are doing the tubular retractor after inserting and going up to the lamina. Usually they do scrap and then to get into the window of the interlaminar space. Now, what's happening? What's happening to the multifidus muscle there? Because it's a claim that tubular retractors do not destroy the multifidus muscle. This is for Dr. Nader and Dr. Kanatha also. Maybe the other surgeons who are using this technique.
Well, as I was saying, hello?
Yeah, Dr.
Okay, yeah. Because I feel that, because we are not really cutting the muscles.
Yeah.
So I don't think so that there is actually any, we do not really destroy the multifidus muscles. Is there any paper to suggest otherwise, Dr. Pathipan?
Yeah, because I've been thinking about it because I've seen surgeons after reaching the lamina, the movements which is being done to reach the interlaminar space.
Yeah.
It obviously take over the superior cell. Obvious. Otherwise, we will not get the exposure of the kind which is being shown through the tubular retractor. Dr. Kanatha.
Yeah.
I don't Dr. Nader's opinion because many times, because I discussed this matter with many surgeons. When we use the multifidus is a very strong muscle, but it has a multiple connection, not one level. It connects to 3 level, 4 level. So when we operate at one level, for example, only at L4, L5, dissecting that region, that is going to change the muscle's potential. I'm talking about clinically.
I mean, for me, I think, I mean, that the tubular system would be a better system as opposed to our conventional, because I mean, of course, you are going to disturb the muscles. I mean, if you say even by just you introducing the system, you're not going to destroy, I mean, or injure the muscles, then I think it's, I mean, there definitely be some muscle injury, but I think the extent of muscle injury is much less. So yeah, that's what I feel.
Okay.